Today on the deep dive, we're tackling aspiration pneumonia. Now, it might sound, straightforward, but trust me, there are some really crucial details that once you get them, will really solidify your understanding.
Absolutely.
You've shared some comprehensive notes on this, and our mission today is basically to pull out the absolute essentials, connect those vital dots, and just make this stick in your mind.
Exactly. We're going to break down, what aspiration pneumonia actually is, the different ways it can happen,
Right.
who's most at risk, how you spot it, the key tests, how it's managed.
And the outcomes.
Yeah, the potential outcomes and complications too.
Mhm.
Think of this as your streamlined, sort of high-yield guide so you feel totally confident with it.
Perfect. Let's dive in. So, starting right at the beginning, what exactly is aspiration pneumonia?
Right. So at its heart, it's basically a lung infection.
Mm-hmm.
And it kicks off when you inhale something you shouldn't. Things like food, liquids, even stomach contents like vomit into your lungs.
Okay, so foreign stuff gets into the lungs.
Exactly. And this unwanted material causes inflammation and then infection. And it primarily hits the lower parts of your respiratory system, the lower airways.
Right. Foreign material in lungs equals inflammation plus infection. Pretty clear. How does that actually happen, though? What's the air mechanism?
It's usually the aspiration or inhalation of either stomach contents, maybe because of reflux or vomiting, like I said, or even just secretions from your own mouth and throat.
From your mouth?
Yeah, making their way down to those really delicate lower airways where they shouldn't be.
But surely our bodies have ways to deal with little bits of accidental inhalation, coughing and stuff.
Oh, absolutely. You've got your cough reflex, which is trying to expel anything foreign, and then these tiny sort of hair-like structures in your lungs called cilia,
Ah, yes, the cilia.
which work constantly to sweep debris upwards and out. But, when a larger amount gets inhaled, or if those defense mechanisms are weakened for some reason,
Like if someone's unwell or sedated.
precisely, that's when problems can really start.
Mm.
We might see things like chemical pneumonitis.
Which is irritation from the substance itself.
Exactly. Inflammation caused directly by the irritant like stomach acid, not necessarily bacteria straight away. Or you could get airway obstruction or a full-blown bacterial infection setting in.
Okay. And you mentioned it tends to affect specific areas.
Yes. Interestingly, aspiration does tend to favor particular spots in the lungs. Most commonly, it's the apical and posterior segments of the lower lobe of the right lung.
The right lung. Why the right?
Well, think about the anatomy. The right main bronchus is a bit wider and more vertical than the left.
Ah, so gravity just sort of funnels it down that way.
Pretty much, yeah. Gravity's pulling that material down, and the right side offers a slightly more direct path.
Makes sense. Right lung, lower lobe, back and top bits. What if someone's lying down, though? Does that change things?
Good point. If someone's lying on their back supine, then aspiration can end up involving the posterior segment of the upper lobes.
Upper lobes this time?
Yeah, again, it's just about gravity influencing where that inhaled stuff ends up depending on posture.
So fundamentally, it's about the wrong stuff getting into the wrong place, causing trouble, often in predictable spots.
Okay, let's shift to why this happens. What are the main causes? The etiology.
Yeah, we can broadly break the causes down into a few key areas. First, as we've sort of touched on, is inhaling gastric contents, often linked to acid reflux or vomiting.
Okay.
Second is aspirating oral secretions, stuff from your mouth and throat. This can happen if someone's ability to swallow is impaired or maybe their level of consciousness is reduced.
Right.
And third, less common but still important, is aspirating actual foreign bodies, like, small objects or other substances.
So those are the ways the material gets in. What about the infection side of things? What kind of bugs are usually involved?
Right, so if the aspiration leads to an infection, the specific bacteria, the culprits, can vary quite a bit. It really depends on where the aspiration happened.
Community versus hospital? Exactly. So in community-acquired cases outside of hospital, we often see bacteria like Streptococcus pneumonia, Staphylococcus aureus, Haemophilus influenza, and then various anaerobic bacteria.
Anaerobes. Those are the ones that don't like oxygen.
That's them. Things like Peptostreptococcus, Fusobacterium, and Prevotella species. Oh, and also the Streptococcus milleri group is quite common too.
Okay, that's quite a list for community acquired. Is there a way to remember those? A mnemonic, perhaps?
There is. How about this? Some silly hamsters always practice freely, and sometimes mingle.
Okay, let's break that down.
Some Streptococcus pneumonia.
Silly. Staphylococcus aureus? Hamsters?
Haemophilus influenza always practice freely.
Anaerobes, Keptostrepto, Fusobacterium, Prevotella?
Perfect. And sometimes mingle.
Streptococcus miliary group. That's actually really helpful. Some silly hamsters always practice freely and sometimes mingle. Got it.
Glad it helps. And within that community group, there's a specific one to flag. Klebsiella pneumonia. Yeah, it's particularly associated with cases where alcohol misuse is involved.
Yeah.
That's a really key link to remember for exams.
Klebsiella and alcohol misuse. Noted. Okay, so that's the community picture. What if the aspiration happens in hospital? Nosocomial.
Right. So in contrast, for nosocomial aspiration pneumonia, the typical suspects shift a bit. You still see those oral anaerobes like Peptostreptococcus and Peptococcus.
Okay.
But you also tend to see more gram-negative bacilli. Things like Klebsiella pneumonia again, Escherichia coli, E. coli, Enterobacter species, and Pseudomonas aeruginosa.
Pseudomonas. Often trickier to treat.
Can be, yeah. And crucially, in the hospital setting, we absolutely have to consider methicillin-resistant Staphylococcus aureus MRSA.
Ah, MRSA. Right. That's a big concern.
Definitely. Because those infections can be much harder to manage effectively. So yeah, the who of the infection, the bug, really depends on the where, community, or hospital and the patient's specific circumstances.
Makes complete sense. So who is most likely to actually experience this? What are the key risk factors we need to be aware of?
Well, there's a pretty wide range of factors that can increase someone's susceptibility. A really big one is anything that impairs a person's level of consciousness.
Like what specifically?
Things like drug or alcohol misuse, being under general anesthesia, having seizures, being heavily sedated maybe after an acute stroke, certain central nervous system lesions, or even a significant head injury.
Basically, if you're less aware.
Your protective airway reflexes, like coughing or gagging, might be sluggish or even absent. So, higher risk.
Okay, reduced awareness is key. What else?
Well, poor mobility can play a role. Also, being kept nil by mouth for long periods. Increasing age itself is a definite risk factor.
It's getting older.
Yeah, reflexes can slow down, swallowing might become less efficient.
Yeah.
Also, having chronic obstructive pulmonary disease, COPD, that's a risk factor. Interestingly, studies suggest being male and taking an increasing number of medications can also increase susceptibility.
Right. COPD, age, male, polypharmacy. What about swallowing problems directly? That seems like a major one.
Oh, absolutely. Difficulty swallowing what we call dysphagia is a huge contributor. This can be caused by loads of things. Structural problems like esophageal strictures.
Narrowing of the food pipe.
Yeah. Or neurological conditions like stroke or bulbar palsy. Diseases affecting the pharynx like malignancy.
Cancer.
Yes. And neuromuscular disorders like multiple sclerosis. Anything that messes with the complex process of swallowing.
Okay. Any other specific conditions or situations?
Yeah, a few more to mention. A tracheoesophageal fistula, that's an abnormal connection between the windpipe and the food pipe.
That sounds risky.
It is. Being on a ventilator, that's a big risk for ventilator-associated pneumonia, which often involves aspiration. Poor dental hygiene or gum disease.
Why is that?
Increases the bacterial load in your mouth, so if you do aspirate those secretions, there are more bugs going down. Gastroesophageal reflux disease, GERD.
Acid reflux?
Yep. Having had surgery to remove part of the stomach, a gastrectomy, having a tracheostomy tube in place. And interestingly, while we used to think nasogastric tube feeding was a massive risk.
The feeding tubes?
Yeah. The thinking now is it's less of a direct risk if it's managed properly, like ensuring the head is elevated.
Okay. So it really boils down to anything that compromises those normal barriers and reflexes designed to keep food and fluids out of the lungs.
Exactly that.
Right. Let's think about the nuts and bolts. What actually happens inside the lungs when someone aspirates? The pathophysiology.
It's really a kind of two-pronged attack, you could say.
Okay.
Firstly, the material that's aspirated food, fluid, whatever, often brings bacteria along with it, so that directly introduces infection and kicks off the body's inflammatory response.
Hit number one.
Hit number one. Then secondly, the mere presence of the foreign material itself, especially if it's acidic stomach contents, can cause direct chemical injury. It literally damages the delicate lining of the lung tissue.
Hit number two, chemical burn. Essentially.
You could think of it like that, yeah. It's this combination, the infection and the chemical irritation, that sets off the whole cascade of inflammation and lung damage that we see in aspiration pneumonia.
So the lungs are getting assaulted by both invaders, the bacteria, and irritants, the foreign stuff.
Precisely. It's a double whammy.
Okay, clear. So we know what it is, why it happens, who's at risk, and what's going on inside. But how do we make sure it is aspiration pneumonia? What else could present similarly? Let's talk differentials.
Yeah, that's crucial because You know, a cough and a fever don't automatically equal aspiration pneumonia. There are several other conditions that can look quite similar.
Such as?
Well, the obvious ones are other types of pneumonia, your standard community-acquired pneumonia or other kinds of hospital-acquired pneumonia. We also need to think about things like a lung abscess.
A collection of pus.
Exactly. Or pulmonary embolism, a blood clot in the lungs, and just other general respiratory infections.
So differentiating from other lung infections is key. Anything else, perhaps broader?
Yeah, if someone's just presenting with, say, difficulty breathing, we need to cast the net a bit wider. Could it be bronchiolitis or croup or epiglottitis, especially in kids? Is there actually a foreign body properly stuck in the airway somewhere? Could it be an asthma flare-up? Or even sometimes cardiovascular disease can cause shortness of breath.
So it's really about looking at the whole clinical picture, the patient, the symptoms, the risks, and ruling out those other possibilities.
Absolutely. Context is everything.
Right. How common is this? What does the epidemiology look like, particularly, say, in the UK?
That's a good question. The precise prevalence, the exact numbers for aspiration pneumonia in the UK aren't actually definitively known.
Oh, really?
Yeah, it's hard to track perfectly. However, we do know it's seen much more frequently in older adults and in individuals who have those underlying medical conditions we talked about.
Which fits with the risk factors.
Exactly. It aligns perfectly. So while we don't have a single number, we know it's more common in those vulnerable populations.
And where do we tend to see these cases?
Well, it's a condition that crops up across different healthcare settings. You see it in the community, in nursing homes, and definitely in acute hospitals.
Okay.
And interestingly, it's estimated to be linked to around maybe 10% of community-acquired pneumonia cases, specifically in elderly patients.
10%? That's quite significant.
It is. It suggests it's a really important factor in pneumonia for that age group. And as we've sort of alluded to, it's also frequently encountered in hospital settings as a type of nosocomial infection.
Right. Any other key epidemiological points?
Yeah, one thing to remember is that aspiration pneumonia often involves multiple types of bacteria. It's often polymicrobial, especially including those anaerobes we discussed.
The ones from the mouth.
Often, yeah.
Mm.
And just to reiterate the demographics, in terms of who's affected, there seems to be a higher prevalence in men, very young children, and again, elderly individuals.
Men, young children, elderly.
So, yeah, while exact figures are tricky, we know it's a significant issue, especially in those specific groups.
Okay, got the picture. Now let's get practical. How does someone with aspiration pneumonia actually present? What are the key clinical features you'd look for?
Right. The symptoms can definitely vary from person to person, but there are some pretty common ones to watch out for. Respiratory symptoms are usually front and center things like a cough.
Productive cough. Wet cough.
Often, yeah. Often are producing sputum.
Mm-hmm.
And shortness of breath, feeling breathless, those are very typical.
Makes sense. What about signs of infection?
Fever and chills are also common, indicating the body's fighting something off. Patients might complain of chest pain. And importantly, especially in older adults, sometimes the first sign might be confusion or a change in their mental state.
Confusion in the elderly, always a red flag for infection.
Absolutely. It can be a key early indicator for them.
Okay. Any other, maybe more general symptoms?
Yeah, sometimes there can be more non-specific things going on too, like headache, feeling sick or actually vomiting, loss of appetite, anorexia, muscle aches, myalgia, and even weight loss if it's been going on a while or recurring.
And other respiratory things.
Yeah, you might hear the term dyspnea, which is just difficulty breathing, and pleuritic chest pain. That's the sharp pain that gets worse when you take a deep breath or cough.
Ouch. And the sputum itself, anything characteristic?
Well, as I said, it's often produced, and it might be purulent.
Meaning?
Thick, yellowish, or greenish in color. That really suggests a bacterial infection is likely going on.
Okay. And if you examine the patient, what might you find?
On physical examination, you might notice signs like a rapid heart rate tachycardia or rapid breathing tachypnea.
Body working hard.
Exactly. Listening to the lungs with a stethoscope, you might hear decreased breath sounds over the affected area, or perhaps a dull sound when you tap on the chest over areas of consolidation.
Consolidation being the lung tissue filled with fluid or pus.
Precisely. And in some cases, you might even hear something called a pleural friction rub.
What's that sound like?
It's described as a sort of scratching or grating sound. It happens when the inflamed linings of the lung, the pleura, rub against each other during breathing.
Right, those are useful signs. What about more severe cases? What are the warning signs?
In really severe cases, patients can develop hypoxia, low oxygen levels in their blood, which you might pick up with pulse oximetry or blood gases. And they can even progress to septic shock.
Which is life-threatening.
Absolutely. A systemic, severe response to the infection. So the key to suspecting aspiration pneumonia often comes down to seeing that combination of respiratory symptoms, signs of infection, and having those risk factors we discussed earlier.
Putting all the pieces of the puzzle together. Okay, so let's say you suspect it based on all that. What are the next steps? What investigations do you order?
Right. When you suspect aspiration pneumonia, the LO, the initial and usually the most important investigation, is a chest x-ray.
The classic chest film.
Exactly. That imaging can help us actually see what's going on in the lungs, look for those lung infiltrates or areas of consolidation that are characteristic of pneumonia.
So the X-ray confirms inflammation or infection in the lungs. How do we figure out which bug is causing it?
Good question. To try and pinpoint the specific organism responsible, getting a sputum sample for culture and analysis is crucial.
Trying to grow the bacteria in the lab.
Yep. Collect a good sample, send it off, see what grows.
What about blood tests? Are they useful?
Oh yes, definitely. Blood tests provide loads of valuable information. We typically look at the full blood count, especially the white blood cell count. It's often elevated something called neutrophil leukocytosis when there's a bacterial infection.
More white cells fighting the bugs.
Right. We'd also check inflammatory markers, like CRP. Basic things like electrolytes and kidney function are important too, checking for dehydration or any imbalances. And blood cultures.
To see if it's spread to the blood.
Exactly, to see if there's bacteremia.
And assessing breathing properly.
For that, we need arterial blood gases, or ABGs. They're really important to evaluate the patient's oxygen levels, carbon dioxide levels, and just their overall respiratory function, how bad the gas exchange is affected.
Okay. Anything else on the sputum?
Well, sometimes culturing the sputum, as well as identifying the main pathogen, might reveal organisms that you typically find in the throat, the pharynx. They can give you extra clues that aspiration of oral secretions might have been the trigger.
Ah, interesting. Do we ever need more advanced scans? Like CT?
Generally, a lung CT scan isn't needed for a straightforward diagnosis, but it might be used in more complex cases, perhaps if the patient isn't responding to treatment, or if you suspect a complication like a lung abscess.
Okay. And what about actually looking inside the airways? Bronchoscopy?
Yeah, in certain situations, bronchoscopy might be used. That's where a small, flexible camera goes down into the airways.
Why would you do that?
It can be helpful to get really targeted specimens for culture, especially if standard sputum samples aren't helpful. Or if you suspect there might be an actual foreign body lodged down there that needs removing, or maybe an unusual infection.
Makes sense. So it's really a combination. Imaging to see the lungs and lab tests, sputum, blood to identify the infection and see how the body's coping.
That sums it up nicely.
Right. We've got our diagnosis. Now the crucial part. How do we manage aspiration pneumonia? What's the treatment plan?
Managing it involves several key areas, really. First and foremost, you need good supportive care.
The basics.
Absolutely. That means things like providing supplemental oxygen if the patient's oxygen sats are low and making sure they're adequately hydrated, maybe with IV fluids if they can't drink enough.
Oxygen and fluids. Got it. What about targeting the infection itself?
Right. Antibiotic therapy is the cornerstone of treating the actual infection. The choice of antibiotic is really important and depends on, well, several things.
Like what?
Like the identified or suspected bugs, whether it was community or hospital-acquired, how severe the illness is, local antibiotic resistance patterns.
So it needs careful thought.
Definitely.
Yeah.
Alongside antibiotics, chest physiotherapy can be really helpful.
Physio. How does that help?
It uses techniques like percussion, vibrations, and postural drainage to help loosen and clear mucus from the lungs, making it easier to cough up.
Ah, clearing the airways.
Yeah.
Good. Any other crucial management aspects?
Yes, absolutely vital. Is addressing any underlying risk factors that led to the aspiration in the first place.
Stopping it happening again.
Exactly. That might mean working with speech and language therapists to assess and improve swallowing function, or treating conditions like GERD more aggressively. If there's a big mechanical obstruction from something aspirated, bronchoscopy might be needed to physically remove it.
Okay.
Sometimes, very early on, maybe in A&E, tracheal suctioning might help clear some material. And in the most severe cases, if the patient develops respiratory failure.
You might need ventilation.
Yes, they might need intubation and mechanical ventilation with positive pressure to take over the work of breathing.
You mentioned tailoring antibiotics. Can you give a bit more detail there?
Sure. The specific antibacterial choice, as I said, is tailored.
Yeah.
You consider the patient, the setting, community or hospital,
Yeah.
severity, local bug patterns, resistance, and obviously any culture results you get back.
What about steroids? Do they have a role?
That's a good question. The role of corticosteroids in treating aspiration pneumonia is currently uncertain. It's not standard practice.
Okay, stick to the antibiotics and supportive care.
Primarily, yes. Other supportive things might include careful fluid balance, maybe bronchodilators like salbutamol if there's wheeze or bronchospasm, and that ongoing physiotherapy. And really can't stress this enough, that referral to speech and language therapy, the SALT team.
For the swallowing assessment.
Yes, it's often absolutely essential for long-term management and preventing future episodes. It's a multi-pronged attack. Fight the infection, support breathing, prevent it happening again by tackling the root causes.
Okay, a comprehensive approach. Now, thinking about the future for these patients, what's the outlook? The prognosis?
The prognosis.
Yeah.
It can vary quite a bit, unfortunately. It really depends on several factors.
Such as?
Things like how severe the initial infection was, the patient's overall underlying health, that they have lots of other medical problems, how quickly treatment was started is crucial, and of course, whether any complications develop along the way.
So generally, worse underlying health or more severe infection means a poorer outlook.
Generally, yes. And complications are definitely more likely in individuals who might be immunocompromised for some reason, or those who already have pre-existing lung problems like severe COPD.
Right. Which underlines the importance of prevention, I suppose.
Absolutely. Prevention is definitely better than cure here, if possible. And simple measures can make a difference.
Right.
Like we mentioned, just keeping the head of the bed elevated to at least 30 degrees, especially for patients who are bedridden or have feeding tubes, that can significantly reduce the risk. For those at really high risk because of, say, a poor gag reflex or known severe dysphagia, then considering alternative feeding methods, maybe NG feeding initially, or even longer-term options like a PEG tube, might be appropriate after careful assessment.
So simple things like positioning and then considering feeding strategies for high-risk people.
Exactly. Early recognition of the risks and getting those preventative strategies in place promptly are absolutely crucial for improving outcomes and preventing serious issues down the line.
Makes sense. Finally, let's touch on those complications you mentioned. What are the main serious problems that can arise from aspiration pneumonia?
Unfortunately, yeah, it can lead to several pretty serious complications if not managed well, or if the patient is particularly vulnerable. We mentioned lung abscess.
The pocket of pus in the lung.
Yes. Also empyema, that's pus collecting in the pleural space, the cavity between the lung and the chest wall.
Nasty.
Very. Respiratory failure is a major risk where the lungs just can't cope. And sepsis, that overwhelming systemic infection response.
Sepsis, again, always a danger.
Always. There's also the risk of getting recurrent episodes or developing chronic lung infections after the initial aspiration pneumonia. If it's left untreated or not managed effectively, it could potentially progress to more serious long-term conditions, like bronchiectasis.
There's permanent lung damage.
Yeah, permanent widening and damage to the airways, making them prone to infection. And as we touched on earlier, in the acute phase, it can lead to acute respiratory distress syndrome, ARDS.
ARDS, very severe lung injury.
Extremely severe, yeah. So these potential complications really highlight why getting that timely diagnosis and putting the right management in place quickly is just so vital.
Absolutely. Okay, so to quickly recap them, aspiration pneumonia, lung infection from inhaling foreign material. Risk factors are key. Think impaired consciousness, swallowing problems, age, certain conditions. Diagnosis uses imaging like chest x-ray, plus cultures maybe. Management is about antibiotics, supportive care like oxygen and fluids, just physio, and crucially, tackling the underlying cause with SALT input.
Spot on. And prognosis varies depending on severity, patient health, and complications like abscess, empyema, or even ARDS. Prevention is key where possible.
Hopefully this deep dive has really helped clarify those key aspects of aspiration pneumonia and given you some memorable ways to think about it, like that mnemonic.
Keep these points firmly in mind as you continue your learning and your MSRA prep.
And maybe consider how seemingly simple things like swallowing can become so complex, and how understanding these underlying mechanisms is just fundamental in day-to-day clinical practice. For more really in-depth revision materials, loads the practice questions to test yourself, do check out passmsra.com.
And for additional free resources to support your MSRA preparation, you can head over to freemsra.com.
Thanks for taking this deep dive with us today.